Hi, everyone. I just want to thank you for tuning into our webinar today for Getting to Zero Illinois. We're really excited to do a brief plan walkthrough with everyone to share the plan that we released this month. So thank you all for tuning in. So again, this is Getting to Zero Illinois. We're here to talk about our final plan release, which we released a couple weeks ago. My name is Sarah Simelka. I'm a program manager here at the AIDS Foundation of Chicago. I'm also presenting today with me will be Meg McElroy. She's a project specialist here at the AIDS Foundation of Chicago. After we walk you through some of just the basics, the nuts and bolts of the plan, we'll also have our featured guest presenters today. We're really excited to have them join us. Both Erik, Glenn, and Toyin Adeyemi are members of the GTZ-Illinois Steering Committee who have been working on this plan for literally years, and we're so excited to hear their thoughts and reflections and what they're excited about when it comes to getting to zero. So Erik is the executive director of the Chicago Black Gay Men's Caucus, and Toyin Adeyemi is the senior director of HIV services for Cook County Health. So we'll be hearing from them shortly, and we're really excited to hear what they have to say today. But first, before we dive in, just a few housekeeping items about the webinar itself. We're scheduled to go for 1 hour today. Everyone tuning in, thank you so much for your time today. All participants that are tuning in are on mute during the webinar, but we would love to answer any questions to the best of our ability, and you can do that through the chat function. So if you type in questions to us, we'll be getting those throughout, and we'll be taking breaks so that we can answer any questions that you have. Lastly, just want to say the webinar will be recorded, and we will distribute this link afterward. We would love for you to share this with your colleagues, your networks, your friends, anyone you think would be interested to know a little bit more about getting to zero, and if you can promote it through your networks, that would be great. All right, so with that, we will just dive right in. And before we get going, I did also just want to give a quick shout out and thank you to our Getting to Zero Illinois Steering Committee and staff. Like I said, this has been like 2+ years in the making. These folks here who have been the head of these various committees that you can see and their at-large members have put so much work into this. A lot of their insight, their community connections, they've poured a lot into this, and we're really happy that all of this work has come together to make this plan. So thank you again to the steering committee and staff. So all of this plan, everything that we are presenting today really is in the hope and in the vein and with the momentum that we can change the course of the HIV epidemic in Illinois. We're really excited about that, and we are really proud of the progress that our state has made in reducing HIV transmissions, but we know that we still have a ways to go, and that we can really impact the course of this epidemic by bringing down transmissions if we increase PrEP uptake by 20 percentage points, and if we increase viral suppression by 20 percentage points. We call that our 20 + 20 target. And if we can hit that, if we can really bend those curves downward, again, by bending the curve of our epidemic transmissions downward, we can really see fewer than 100 new cases by 2030. And that's the ultimate goal. That's what we're driving at with getting to zero. Which kind of leads into the next point, because when we say getting to zero, what do we mean by that? Ultimately, we'd love to see 0 new transmissions and 0 people living with HIV who are not on treatment. However, we know that that is kind of in our ideal world, and we're living in reality. And so what we are really aiming for within this specific project of getting to zero is functional zero. And what that means is fewer than 100 new transmissions per year. And that would really take HIV out of epidemic status. It would make HIV something that new cases are very, very rare. They are isolated. Right now, that's not the case. So that is the goal of by 2030, reaching functional zero, to get fewer than 100 transmissions per year, so that we can, again, take HIV out of epidemic status in Illinois. So again, just really quickly, as we mentioned, how we're going to do that is what we call our 2020 target. So the first 20 percentage points that we're looking for is to increase the use of PrEP. So the challenge with that is that right now, currently, only 10 to 20% of people who need PrEP are taking it. When we say need, these are people that would be great candidates for PrEP, such as Black gay men or other bisexual, gay, or other men who have sex with men, or trans women of color, or Black cisgender women, for example. these all are folks that are impacted by the HIV epidemic, and when we look at those populations, there's just not enough people using PrEP to drive down the transmissions. So that is one of the kind of huge overarching goals of getting to zero, and something that a lot of our goals and strategies are aiming toward. And then the second kind of big element of getting to zero is U equals U. So we know that undetectable equals untransmittable, which is great. That's people who are virally suppressed for 6 months cannot sexually transmit HIV to a partner. This is amazing science. It is amazing news. We're really excited about this for 2 reasons. One is that people living with HIV who are virally suppressed, they live longer, healthier lives, and their quality of life is improved. That in and of itself is amazing and something we want to share and really celebrate, and also encourage people and help them and support them to get virally suppressed so that their own quality of life is increased. However, U equals U tells us there's a double benefit of viral suppression, which means that it really cuts down on transmissions, because someone who is virally suppressed cannot transmit HIV sexually. So that is all great news. That's what we're driving towards. The challenge with it is that about 50% of people living with HIV in Illinois are not virally suppressed. So again, that's why we want to drive up viral suppression through various strategies through the Getting to Zero plan. So those are the kind of the 2 main elements of getting to zero, the 20 plus 20 target. What we're going to do today is talk a little bit more as how we're going to get there. We are really excited that our plan is officially launched May 14th, 2019. Governor J.B. Pritzker, along with several members of the Getting to Zero Steering Committee and community advocates, officially launched our plan out into the world in Springfield, in the Capitol. We were just so excited that all of our years of work had led to that moment. The plan really lays out our work for the next 5 years to reduce HIV transmissions and increase access to healthcare so that all Illinoisans can thrive. And we are just so proud to have the governor's support. We also had the support of the director of the Illinois Department of Public Health. Really having these large institutions and powerful folks behind the Getting to Zero project will help us really make real impact, we feel, over the next 5 years. So we're really excited to have that support and to start the work. And before we dive into the plan itself, just one last thing. Meg and I, Erik and Toyin, are going to be going over, again, kind of the nuts and bolts of the plan today. Another way you can go over it is online. We have an interactive plan at gtz-illinois.hiv/plan. When you go there, you're able to browse the plan in an interactive way. So as you see on the screen right now, one thing is there's this section called workforce that is circled. There are 6 of those domains, and Meg's going to talk about those in just a minute, but you can browse through and click the domains that are most relevant to you. You'll see that little drop-down arrow is circled. There are strategies under all the goals that will tell you kind of more of the how we have planned to accomplish these goals. And you can also browse by topic. Over on the side, you see there are examples for kind of sections of work, or ways that we divide up the work. So for example, drug and substance use. How does that interact with HIV? How do those services interact with HIV services? Anything involved with that will come up when you click on the drug and substance use. We also know that there are certain populations, as we mentioned before, that are particularly impacted, and so those are also on this side. So if you are, for example, a Black cisgender woman, or you serve Black cisgender women and are wondering how does the plan really address that population, if you click there, you'll see everything that comes up that addresses that specific population. And there's lots more topics too. So we just want to highlight that and tell people that you can definitely go online, click around, and become familiar with the plan online. So yeah, I'm just going to move it on over to Meg now, who will talk a little bit more about our guiding principles and the beginning of the plan.
Sure. So as Sarah mentioned, thank you for tuning in today. And if you have any questions as we're going along, please feel free for questions for Sarah, for myself, for Erik, or for Toyin, to go ahead and type those to us. And at the end, we'll do kind of a Q&A to address those. So the guiding principles of the plan, we have 5 of them, and GTZ really believes that our guiding principles are the core ideas that really inform all of the work that we're doing. So these are interlaced and underlying all of the goals and the strategies found throughout the plan, and they're here on your screen. So with eliminating stigma, We believe that stigma in all forms stands in the way of achieving health equity and the outcomes necessary to end the HIV epidemic. We will fight against suggestions and beliefs that individual choices, like the choice to have sex or use drugs, or the choice to take medication to prevent HIV transmission, somehow creates disgrace or shame because of others' viewpoints. We will unapologetically embrace philosophies, practices, and policies that help us eliminate stigma like U equals U. Dismantling racism is another one of our guiding principles, and we really believe through our work to end the epidemic that we'll actively change and dismantle systems that perpetuate white privilege and racist ideologies. We know that these have created disproportionate impacts of HIV on certain communities, like Sarah was talking about. And so GTZ truly believes that we must end the HIV epidemic for all populations in Illinois, not just some of them. Prioritizing trauma prevention and trauma-informed care. So with this guiding principle, GTZ will ground all of its work in the principles that honor the importance of safety and empowerment. So research demonstrates people living with or vulnerable to HIV experience multiple cascading traumatic events in their life that prevent them from being as healthy as possible and achieving their full human potential. So examples of trauma include childhood sexual abuse, rape, intimate partner violence, gun violence, and witnessing or being victim of a crime. We recognize that we need to make sure to prioritize trauma prevention and to prioritize trauma-informed care when helping people. Practicing cultural humility is a big one for us. Cultural humility centers on being open to differences between self and others and prioritizing spaces for celebrating that which is most important to other persons. It takes the idea of cultural competence a few steps further. And says cultural humility prioritizes making space for a person to continually self-evaluate, to work towards correcting power imbalances and relate other identities, and to serve as an ally with groups and people working towards eliminating disparities. Our final guiding principle, and this is a big one as well, is focusing on data to achieve outcomes. So later on, Sarah's going to talk about kind of our data-driven mission, but really we know to attain our 20+20 target, we have to increase viral suppression and PrEP usage by 20 percentage points, and that these outcomes need to be standardized and measured so we can report back on our success and our progresses. So all of those guiding principles really, again, are interlaced throughout the plan. The plan is made up of 22 goals and 78 strategies that are broken down into 6 wheels or domains that are on your screen. One of the first things that we're going to be doing since we've rolled out the plan is to prioritize these goals and these strategies and then create relevant work groups based on the work that kind of raises to the top for this first year. And that's a process that will be continually reevaluated and done every year throughout the plan. So I'm going to go ahead and walk us through the first 3 just very briefly and chat about kind of what they are and how we hope to achieve them. So building the future workforce is our first domain. It's the W in wheels. And building the future workforce, the HIV healthcare and public health workforce is the backbone of our HIV service delivery system, providing needed services to individuals living with or vulnerable to HIV. As scientific and practical knowledge changes, our workplace must learn new approaches and adapt to the evolving needs of people living with or vulnerable to HIV. So this is saying we want to make sure that people, as they are being trained, as they're continuing to practice, that they are engaging in really sound and competent HIV care. To do this, one of the goals is to increase our training opportunities. So we want ongoing practical training that builds knowledge about HIV, STI, and viral hepatitis care, including science-based education such as PrEP and U equals U for all of the HIV workforce. So we're going to do this through trainings about implicit bias and other oppressive dynamics built into our training curriculums for members of the HIV workforce, and not just for HIV workforce that is our healthcare providers, but the entire HIV workforce. So the next wheel for us is increase access to healthcare. And this is a pretty big one. The wheels are not in any particular order or priority or of importance, but healthcare is one of our larger wheels that we have. So there are quite a few goals in there. I'll just kind of talk on 2 of them for today. So increase the healthcare. People must know that HIV services are available to them and can bring value to their lives. Regardless of HIV status or whether or where a person receives services, people screened for HIV must be linked to high-quality healthcare services that support use of ARV medication for HIV treatment or PrEP, as well as other services necessary to achieve health and wellness. After connecting to healthcare, people must receive needed support to stay connected and to use ARV medications consistently and correctly. So two of the goals that fall under this domain are Goal 5, which is expand HIV screening. So we want to see the number of people living with HIV who know their status increase from 86% to 93% by 2023, which is the first, our plan is broken down into 10 years, so 2023 is the first 5 years benchmark that we have for ourselves. And this would be done by expanding healthcare-based screenings as well as community-based screenings. And then the other goal in healthcare that I wanted to point out is about Goal 10, which is about reducing structural or institutional barriers to healthcare. So we want to dismantle or eliminate structural and institutional barriers that negatively impact ARV use for HIV treatment and PrEP among persons living with or vulnerable to HIV. So we want to increase equitable distribution and access to things like transportation, dental care, food and nutrition, things like that that support people's health and access to healthcare and staying on medications. The final wheel that I am going to talk about today is health equity. So improving health equity, the data is clear that grave disparities exist in the HIV epidemic, and these disparities map to race, ethnicity, sexual orientation, gender identity, age, and a person's other lived experiences. We must use data to define which communities face the greatest disparities and in what context. With this information, we can set tangible and aggressive targets. The first of the goals in this domain and strategies in this section define population-based metrics that will guide investments in our effort to build health equity, baselines for statewide new HIV diagnosis, viral suppression, sustained viral suppression, and PrEP prescriptions, as well as projected targets for 2023 will be established by our GTZ-IL committee by the end of 2019 to consistently measure progress over time and report back actual advancement towards our goals. All goals and strategies have a target completion date of 2023, like I was saying earlier, unless they're otherwise noted in this section of the plan. So for this, we have goals that talk about reducing new HIV diagnoses, especially among our communities, our priority communities that we've pointed out, who have a disproportionately high burden of HIV incidence. Another goal in this is about sustained viral suppression, so increasing our percentage of HIV diagnosed people who have sustained viral suppression among communities, again, experiencing those disparities.
All right, thanks, Meg. So those are the first 3 of domains. I'm going to take us through the second 3 pretty quickly here, and then turn it over to our guest speakers. So just moving right along, the next E is for efficiency. So increase efficiency through governmental coordination. So as you probably know, state and local health departments really do play a key role in organizing, funding, monitoring, and improving quality programs and services for individuals who are either living with or vulnerable to HIV. These big institutions control a lot, and it's a huge part of the programming and services that are rolled out throughout the state. And when these big institutions intentionally and effectively coordinate with each other, the overall system is more efficient, it's more expansive, and it's more effective. And sometimes it can be difficult, like with different priorities and different agendas, to get everyone going in the same direction. And that's one of the huge goals of Getting to Zero. Everyone is across the state is doing great work, and we just want to make sure we're all coordinating. That's like a kind of one of our overriding things. So there's a couple goals nested in this domain. One of the goals, number 18, is to invest in services for people living with HIV. And so with that goal, we want to have state agencies collaborate and coordinate their efforts to increase long-term investments in services that are aligned with Getting to Zero Illinois. So one of the strategies that feeds into that, strategy 63, for example, is to integrate the Getting to Zero Illinois goals, strategies, and action steps into the priorities of existing state programs, but that are outside public health, because this goes outside of public health. So for example, Illinois Medicaid, that's a huge system that needs to pay attention to and serve people living with HIV. And so that's part of our action steps will be like, how do we work with that? Another department, for example, that we don't want to work with that's within the state but not HIV focused is Department of Aging. We know folks are wonderfully living longer with HIV, so they're moving into that aging population. Is the Department of Aging ready to serve folks living with HIV? And if not, how do we help support that and align them with getting to zero goals? So that's an example of government coordination. Moving on to our next wheel, it's L for linked conditions. So this is care for linked and co-occurring conditions. So people that are living with or vulnerable to HIV often need services beyond just HIV services, as we all do. Our lives are layered, there's a lot going on, and HIV is never the only thing that someone is dealing with. So there's things outside of that, such as comprehensive behavioral health care, that's including mental health, substance use treatment, screening and treatment for sexually transmitted infections other than HIV, and vaccinations against sexually transmittable or communicable diseases. Examples of that is viral hepatitis or meningitis. So timely and seamless care for those other conditions will help maximize HIV services. So one of the goals under this, for example, is to expand behavioral health care. The goal would be that behavioral health care is readily available to people that are either living with or vulnerable to HIV, and really decreasing the stigma and removing barriers associated with accessing mental health services or services that deal with substance use disorders. So that is one of our goals. And another goal under that section deals with, for example, STIs and viral hepatitis. We want to reduce the burden of those STIs among people living with HIV. So one strategy that would accomplish that would be ensure that people that are vulnerable to HIV that are diagnosed, for example, with syphilis or rectal gonorrhea, are linked to PrEP services. This kind of also goes back to coordination and making sure that we are using the best practices. If someone walks into a clinic, they are diagnosed, for example, with syphilis or rectal gonorrhea, there should be something in the system that says, hey, we should talk to this person about PrEP, or talk to them about the availability of PEP. So that people are not falling through the cracks, and that we're catching folks before they are exposed to HIV and they're not on PrEP, for example. So now move to our final wheel. In wheels, the S is for surveillance, and that's measuring our progress through surveillance or other data. Meg mentioned this before. This is kind of woven into a lot of our strategies and goals, because our success really relies on our ability to define, measure, and evaluate the goals and strategies that we put forward. So where available, we want outcomes data to be used, and that is essential to measuring our progress. When competing data systems exist, which is a thing for anyone that has worked, there's federal, there's state, there's community data, and they're not all in the same system. So comparing the data can be hard, but where that competing data system might exist, we want people to communicate and offer seamless integration where possible to avoid the duplication of effort, and make sure that that can happen and support that happening. Also, collecting meaningful and timely data at the state, city, and community levels are essential to tracking our progress into the 20+20 target that Meg mentioned. So one of the goals under this domain is goal 22, which is to track and share our progress. So we want to monitor and share publicly with you all and all of your communities and all of your networks our implementation progress. One way to do that is to develop a system, like a dashboard, to allow for monitoring and the dissemination of these indicators. And also, as Meg mentioned before, we have an existing RED committee, which is research, evaluation, and data. We already have that committee. They worked on building the plan, and they continue to exist to help us get those benchmarks so that we can have a baseline and then communicate that out each year. So that's one of the goals. So that's the S. So we have gotten through wheels, and so those are the huge domains under which all of our other goals and strategies live. So I know that we've been talking at you all for a little while, and so I'm going to go ahead and check with Meg if there's any questions that have come in that we can answer before we move on to Erik and Toyin presenting their part.
I don't think we have any questions prior to Erik and Toyin presenting, but there are a couple that have come in. I think that Erik and Toyin will be able to answer at the end, or might address in the next half hour here.
Great. All right, so without further ado, I will go ahead and start by introducing Toyin Adeyemi. She is the Senior Director of HIV Services with Cook County Health. Toyin has been involved in GTZ for several years. She has been a thought leader and someone that has really spread this message out into the community, and has put a lot of work into our steering committee as well. So I'm going to go ahead and turn it over to Toyin.
All right, good afternoon. Thanks, Sarah. Good afternoon, everyone. So in my 15 minutes, Sarah wanted me and Meg wanted me to talk about 4 things. One was, what kind of HIV work I did prior to GTZ, how and why did I get involved in GTZ, what was it like to be part of this very exciting process of putting the plan together, and 1 or 2 things that I'm excited about in the year to come. So I'm glad to be doing this with my co-chair on the Healthcare Access Committee, Erik, who you'll hear from shortly. So my background is since 1999, I'm an infectious disease physician and have taken care of adults living with HIV and or viral hepatitis at the Core Center, one of the clinics within Cook County Health since 1999, so 20 years in this. And that was my work, doing HIV and viral hepatitis care in the outpatient and inpatient setting, but also with a heart for teaching and advocacy, and really doing a lot of work around access to hepatitis C medications for people living with HIV, co-infection, or just viral hepatitis. So again, as part of the initial planning for getting to zero, there were town halls, focus groups, and things where a lot of people from the Core Center were actively involved in. We had a lot of advocates and caregivers and case managers and some of our policy people who were really actively involved in getting the initial community involvement and getting town halls and focus groups and really figuring out where the gaps were, what people were concerned about, where our priorities needed to be. So just really being part of that process, and some of those focus groups were held at Core or facilitated by some of the people I worked with. So that was kind of the momentum, and it was very clear that this was a plan that realized the importance of being patient-centered or client-centered, and that we needed to really address the social determinants of health. So it was something that I really wanted to get involved with, and that was how I got involved initially as part of some of the initial community stuff, and then earlier in 2016, 2017, getting involved in some of the calls around setting together the plan, and then we had our kickoff in June of last year, and that was very exciting, going in to actually sit down with a group of people and start to talk. And so that was the background in doing this for 20 years, knowing that the importance of a client-centered approach, and that we were actually we had the tools to actually do that, where we had enough data knowing that undetectable was untransmittable, and that we had PrEP, which was effective. And so we had the biomedical tools, and we knew that if we could get everyone on the table, prioritizing what needed to happen, recognizing that there were very huge disparities within our city and state, and really being honest about how we're going to address issues around equity and efficiency of how we do things, is how I got involved. Her next thing was, what was it like to be part of the process? It was exciting. So like I said, when we had our June 20 kickoff, it was, to be in the same room with people who were thinking around what we needed to do to get to zero new infections, a very diverse group of people from healthcare, from people from policy, from substance use world, from community advocates, a whole bunch of people, and looking at being able to work in groups with people who had different lived experiences, different backgrounds, different areas of expertise, all working together in a very democratic process, thinking through things. And so being part of that group, and then being broken into different groups. So we had the different committees, initially kind of outside of your comfort zone, but being able to work with people across a whole range of disciplines. So we had, the calls, tons of calls, face-to-face meetings, tons of writing things down, prioritizing. So it was very exciting to be part of that process and to learn about what was already happening in the state. So there were a lot of silos that we have to break down, that were broken down, and part of the plan is continuing to break down those silos. But it was very exciting to get a landscape from the Departments of Public Health about where where we were, what was working, what was not working, where our gaps were, to have input from a variety of people, and then to sit and start to process how we could do this, listening to the policy people, bring in plans from other cities and states, being able to see how we could customize some of those and what we already had working or what wasn't working, but also just the energy, the passion, the enthusiasm of the group. And for me personally, being part of that group, it also allowed me to realize, all the great work that we were doing in our health system around equity and patient-centered approach and addressing those social determinants, but learning about other things that were happening and best practices at other sites that we really, by coming together, could share and not have every site and every system kind of recreate the wheel. So that was really exciting. And just being exposed to people that I wouldn't be in my regular world in the clinic, the creative communications people and how they could take information and figure out how to present it in a client-friendly, forward-facing way, knowing that our audience for Getting to Zero is not just people already in the workforce. We're trying to reach people in the community, people in media, in marketing, people in the justice system. So, being able to see how the creative type people worked, the research policy people, being able to figure out how we're going to track our outcomes, the advocacy. So it was very exciting to be part of the process, putting the plan together and having a multidisciplinary approach and a very democratic process. We ended up with 22 goals and 78 strategies. And I think after the initial plan was, put out, we had double that. I think we had close to 50 goals and 100 and some strategies. But to be able to meet and start to prioritize them, and we're going to have to do that even further as now we get to implementation of what goes in the first year, in the first 3 years. So really, the process was very exciting because for the first time, in a while, we had the tools to actually do this, to get people on prep, but also realizing that it would take a huge approach and everyone on board. And in the last few minutes, the last part was one or two things that I'm excited about. So for those of you who know me, I'm very excitable and I'm very passionate about this. And, there are lots of things to be excited about. The fact that we're harmonizing prevention and care. So we're not having those silos between the prevention guys and the care people. And the fact that even our RFAs and things that are coming from the city and state are including GTZ goals in them so that the same people who do excellent work, keeping people in care and retained and engaged in care when they're living with HIV, can now also work with people vulnerable to HIV and keep them on PrEP. So the fact that we can actually harmonize prevention and care and utilize the workforce to that effect is very exciting. That by this process, we're going to be breaking down a lot of silos between agencies. We're going to have Medicaid be a more visible partner, and we have the support of the Medicaid people and the Department of Public Health, and knowing that the governor did put out the decree that we needed to work together with Medicaid to do that. So I'm excited about those things because those things are going to be really critical. The guiding principles around dismantling racism and eliminating stigma, really important for what we do. And so when I talk about Get to Zero, I use the wheels because even though it's not in any order, we know that, if you have 3 minutes to talk to someone about GTZ, if you use the wheels, then you won't forget what you want to talk about. And so being able to engage the workforce and being part of GTZ, we had college students, we had kids, some of them just right out of high school who were really interested in the advertising part of it, the social media, getting the word out, who were talking about testing and routine testing. So, expanding the workforce, not just for care providers and prescribers, but people who are going to be passionate about communicating and dismantling systems that don't support what we need to do, that are going to be outspoken advocates to make sure that policies that do not support what we need to get done are not, are taken out of place. Those are things that I'm very excited about. From our system, Cook County Health, we already do a lot of work. We take care of a lot of people living with HIV already and talk about a lot of social determinants of health in our routine care. Behavioral care is part of what we do. But one or two things that in that first year is we do plan to, to promote sexual health within a large system and expand, routine asymptomatic STI screening and access to PrEP. We're going to expand the number of sites where we actually provide PrEP, expand our hours so more people have access, and expand where people can get care within our health system. So realizing that some people like a larger clinic, somewhere like the core where they kind of feel like they're anonymous and they don't want to stand out. And some people want a small, intimate place close to home that's a primary care site for them. So we're going to expand routine asymptomatic screening for STIs where we offer PrEP. We're going to do a lot of education with our providers in our system so that we can actually incorporate sexual health into what we do really. So there's a lot of goals. There's 22 goals. There's 78 strategies. But what I really like about the plan is that you can go in there and figure out what's already working and what you can expand on and really get that going. And the fact that we have, one of the largest Medicaid plans, the county care, I'm excited personally to be working with them on how we can actually get to, doing what Ryan White, having the Ryan White standards for what we do around keeping people retained and engaged in care, be the standard that Medicaid keeps up to since they insure a lot of people living with HIV in the state. So I'm excited about a lot of things, and in the next 5 years, there's lots that's going to happen. But really, in the next year, for us within our health system, is really doing more around sexual health and STI screening, PrEP access, and continue to do the work around stigma elimination and Medicaid processes for our patients. So that, I think, was my part. And, once Erik is done, I'm sure some questions will come in. But really excited about getting, more community involvement at our clinics and really prioritizing the goals over the next year. So thank you.
Yes. Thank you so much, Toyin, and we love your enthusiasm, so thank you. I said, Toyin, we're so excited to be working with you and I said the whole system over the next 5 years. So great things to come. So thank you. And next, we'll go ahead and move on to Erik, who is another member of our steering committee and the executive director of the Chicago Black Gay Men's Caucus. Take it away, Erik.
Thank you. So wanted to start a little bit about how I entered into this project. I've had the privilege and honor of working as the executive director of Chicago Black Gay Men's Caucus since 2015. And one of the first projects that I had the opportunity to work on in that new role, because I had just gotten promoted, was the Illinois Getting to Zero task force, or steering committee rather. What had prepared me for that time really was a long line of work with the caucus as an organization that really took seriously the ins and outs of how HIV plays through the lives of Black, gay, bisexual, and same-gender loving men. And something that we tend to say over here a lot is that we know that our lives don't begin and end with HIV. And if we look at our statistics, they tell us that Black gay men are doing a very good job at taking care of themselves sexually, given all the kind of environmental circumstances. But that's not reflected in the data we see when we talk about HIV rates and trends over time, especially compared with our racial and gender counterparts. And so what does the explanation end up being? And so as an organization, we've been very, very interested in tracking down the root causes of the HIV epidemic as it plays out amongst Black gender loving men. We're at a point in history where 1 in 2 Black gay men will contract HIV in their lifetime, at least projected from the latest CDC evidence. This is obviously pretty distressing when we sit down and think about it. We have the unfortunate distinction of being the community that boasts that type of statistic. And so again, immediately come back to, well, what are the causes? And in public health, we talk a lot about social determinants of health, and we recognize them as a way to name what some of these root causes of HIV are. As an organization and throughout my work, Part of that conversation is also recognizing how we're not just talking about HIV. We're really talking about a bundle of intersecting oppressions. And so for Black cisgender-loving men, this looks like the intersections of racism, homophobia, biphobia, at times transphobia. We have ageism and ableism, obviously, as other things that kind of come into the equation, toxic masculinity coming into the equation, and then personal economics and neighborhood economics that come into the equation. So the list just gets longer and longer. How do we organize this? How do we attack these root causes, these social determinants of health, or address these social determinants of health, so we can lead to better and greater health outcomes for Black cisgender-loving men today and down the line? Because we know that there are needs that can't wait, like food and medication, and ways that we can prepare for the future, where we have more livable wage jobs that people are able to participate in, and be able to take care of themselves and their families. And so Getting to Zero came about at a time where our interest in this was really starting to crest and say, how do we have the greatest kind of impact on our local community and our region? Because if we look at where we meet Black gay men, Black same-gender-loving men, they're not just in Chicago. They're throughout the region, and they travel to Chicago for community, and community with an asterisk, because that means a lot of different things. So we necessarily need to focus on social determinants, and we necessarily need to focus on region. Again, Getting to Zero came in at a good time where we were able to not just participate, but really bring that point of view and that priority to the development of the project. So I started with Getting to Zero at the very beginning with my peers, and really found myself in the community engagement lane, where we said, well, look, we have a lot of smart people throughout the state. We have a lot of creative people throughout the state at every level, professional and non-professional alike. How do we work to make sure that we have as many thoughts, inputs, advice, reactions associated with the development of this plan? And so me, along with the steering committee, came to the conclusion that really a framework was the place to start, which eventually developed into the plan that we're talking about today. I claim no kind of like great participation in making that decision. I was just around when it happened. I'm very happy that it played out that way, because it gave us a stepped way to proceed in developing a plan that had a pretty high call. The charge was to accommodate the entire state of Illinois. And we know that in some ways geographic barriers are illusions, and people travel back and forth. And so in some ways we're not just talking about Illinois, we're talking about Illinois and those that interact with Illinois. When we're talking about different populations that are impacted to varying degrees, because the way that intersecting oppressions hit them varies by the identities and the social groups that they are affiliated with, and the way that they're treated by the environments that they're located in. And so it gave us a chance to really take it step by step. And so those of you that heard about the framework when it was initially developed will know that this has been a plan in the making. I think that when our lovely hosts were mentioning how we've been involved for years, I was like, wow, it has been years, because to develop a plan of this scale, and when I go back into it, I'll let you know about some of the highlights. Developing something like this with a certain level of simplicity so that we're all able to move forward in a straight line together is an undertaking. And it was a surprise to me, because it's the biggest plan that I've worked on in my professional career, how much was involved and how much time that took, and what kind of investment that took from various organizations, AIDS Foundation of Chicago, Chicago Department of Public Health, Illinois Department of Public Health, devoting staff time, the Caucus obviously devoting staff time, to make sure that we're not just coming as volunteers who pop in every now and then, but this becomes another project that is part of the work that we do. And that type of investment is something that was relatively new for me to experience, and it turned out feeling very, very good. And so to give you all a little bit more of how the sausage was made, we did have our steering committee sitting around the table having conversations about how important representative leadership is. Spending time delving into community engagement practices so that we can get ideas before the framework is developed and before the plan is developed, so that that could be part of the initial work. And then more community engagement practice to get a reaction to how far we were able to go. And now we're at another point where we're still working to engage our communities to make sure that as the plan is implemented, this is really where the rubber hits the road. You say, well, what does this look like in practice? And I'm sure all of you listening right now are thinking, well, okay, plan, I'm on board, this sounds great. Or maybe I have some questions and I'm not sure what to do with those. Either way, I would continue to push. Those of us that are part of the steering committee are very interested in what everyone has to say. That is a very large undertaking. I think Sarah and Meg can attest to that. Because to give credit where credit is due, they're doing, those two are really doing such a lion's share behind the scenes to make sure that this plan represents all the voices that have been included along the way. So there's some things that make this plan a little bit different than ones that I have read and that have guided me in the past. So we think, well, Illinois used to have an HIV strategy years ago. We are just coming out of having a national HIV/AIDS strategy for the first time, the status of which is a question mark. And so what makes this plan special and different? Well, I can tell you from my perspective, at a time, again, where we're talking about 1 in 2 Black gay men being infected in their lifetime, this is something that's very serious to me professionally and very serious to me personally as a Black gay man myself. So how do I know? And how do the people that I represent know this plan will take us somewhere different? Well, I can tell you some big differences that hit me from the beginning. From the beginning, having a process that is open to reconsideration. The process of getting to the Wheels organization took a hot second. But I'll tell you, if I think about my favorite parts of the plan, having improving health equity spotlighted and called out in a way where reducing new HIV diagnoses for Black gay men and other racial and ethnic minorities is front and center. Where developing our workforce is front and center, because for many of our organizations, we don't just serve our community. We are biaspora, which means that we employ and work to really fulfill the leadership potential of those who are part of our community through employment. Focusing on how they fit in our workforce, how different planners and decision makers fit in, and how lay people and community members fit in also is something that's special about this plan. We have tools that we've never had before that are very exciting to see scaled up, like PrEP usage. And so if you think about some of the earlier slides where we talked about, well, what are the goals that undergird this plan? Well, the two goals end up being increasing PrEP use and increasing retroviral use for HIV treatment. Both of these things are not new, but a perspective is new where we say, how many people in our community need to be on PrEP? It's not everybody, because we know as a truth that PrEP isn't good for everybody for a variety of reasons. It's not the right time in my life. I'm still trying to figure out how insurance and payment works. I'm not so familiar with the healthcare system. Me and my partner just said no, didn't think it was a good fit for us right now, or I used to and now I don't anymore. All these different situations, how do we accommodate all of this while saying we want to scale up the uptake? Well, we need to know how much we want to scale it up. And so for a plan like this, leaning on evidence, data, and scientific modeling has been really helpful, and something that I haven't encountered to this level before, where we can say we want to raise the amount of PrEP usage by 20%. This gives a marker to all of us who work in client services to say, well, now I have a threshold that I can work off of. And those of you who might be saying, well, is it 20% for everyone? 20% we generally think of as an average. And as time goes on and we dig even deeper into some of the elements of the plan to make recommendations for those of you who are interested in implementation, we can say, okay, what is the precise percentage increase that we would need for a particular population? What type of investment would we need on X, Y, and Z social determinants to assist in that? Again, also on the uptake of antiretrovirals for HIV treatment side. We've been very lucky. Chicago Department of Public Health, for instance, has made a significant investment in supporting getting to zero and the ideology that goes along with getting to zero and the strategies that go along with getting to zero through their new HIV service portfolio. Chicago Black Infants Caucus is one of the proud recipients of a new type of grant opportunity using community development as a means and an end to developing structural interventions. Structural interventions that would directly impact the social determinants of health that are negatively impacting the health and wellness of men in our community, specifically around their sexual health and specifically around HIV rates. And so we have an opportunity not just to move forward with the plan, but also to synchronize, as is indicated in the plan through government coordination, with our partners to level up all of the work. And so the caucus is an example for those of you who are looking for opportunities to get into implementing the plan. We'll be taking information from this grant opportunity and project and feeding directly back into the elements of getting to zero and developing models of work that we will be sharing with our colleagues around the state to implement that will directly address root causes of HIV. So I think I'll stop there. I can't stop, I think, singing the praises of the plan because I'm just very excited that it's together. It is the culmination of a lot of time and a lot of effort and a lot of investment. And I'm interested to hear what our audience has to say for more information and particularly around how to implement.
Awesome. Thank you so much, Erik, for speaking today, and also, like you said, for your years of investment and work and pushing the steering committee to really, truly make this a comprehensive plan. So thank you so much. And yeah, I'm going to go ahead and turn it over to Meg. We have had some questions come in. Just as a time check for everyone, we have about 7 minutes left. If we don't get to your question, we have logs of all the questions and we can follow up with you personally, but we'll try to get through what we can. So I'm going to go ahead and say Meg has been keeping track of the questions, so go ahead, Meg.
Yeah, okay, the first question that we had from a participant was about Spanish language in the plan. So is the plan available in Spanish?
Yes. Oh, this is Toyin. Yes, it is. Fully translated plan available in Spanish. And that was very clear and intentional that not just the certain parts of the plan or the parts that were going to be used in clinics, but that the whole plan be translated, and the whole steering committee voted for that. One, because our priority populations include Latinx men, and we also have immigrants and migrants as priority populations. And in addition to that, many of our clinics and facilities have monolingual Spanish-speaking patients. And the goal was not to have the plan only be for the healthcare providers who would then translate, but that every member of the community could get online, get on the stuff, and download what parts were pertinent to them. Because the goal is that we have people in marketing, people in the community, people at high schools, people at community events can get on the website, tab a certain population, a question around aging, around PrEP, find what is needed, print it out in real time, or send a link. So yes, it is available in Spanish, fully translated.
Yep. Thank you, Toyin. And yeah, just a note that she did mention too, the website also is available. You can click a button at the bottom to switch the whole thing over to Spanish. So that's another way that it is in Spanish. And we also have executive summaries of the plan. If you are trying to, again, like give this to your boss, or colleagues, or just have a quick summary, the executive summary is in English and Spanish as well through our website.
All right, the next question, Erik, is for you, and it's about how did we select the different priority populations? And just so everybody on the phone knows, the priority populations that are spelled out in the plan in our health equity section are Black, gay, bisexual, and other men who have sex with men, Latino and Latinx, gay, bisexual, and other men who have sex with men, cisgender, Black, heterosexual women, and transgender women of color.
It's an important question. I think this is something that needs to be wrestled with every time we come back to even considering who priority populations should be. We come back to the data, and what is the data telling us? And there are two things that we have to balance. So proportion and rate. So we say, well, who is really shouldering the disproportionate amount, so more than they should, if everything were equal, of the HIV epidemic. And so another way of saying that is, if we have a pie and we say, well, this proportion of the overall population of Illinois is Black, if all things were the same, we'd say, well, our Black population, for as much as you are the population of Illinois, that's how much you are of the Illinois HIV epidemic. And we know that these rates are wildly inconsistent. They don't balance out between how much of the population and how much of the epidemic, because there are disparities. You say, okay, well, disparities, and then also just how many people, if we say actual numbers. Crunching those together, for a lot of us, it was really obvious who our list of priority population should be. But I want to say, in an effort to move away from kind of a crabs in the barrel mentality of, well, if we're not a priority population, then we don't get addressed. Part of how the plan is written is to make sure that it is as universal as possible. Sitting on top of that, we make sure that we call out specific populations, mine included, who are at a level, who experience a level of disparity that is way too significant. For me, it's hard to argue with 1 in 2 Black gay men contracting HIV in their lifetime as not just a immediate call to action. And many of our racial and gender peers as communities are experiencing the same thing. Now, we may, coming years down the line, say, well, we're going to course correct and say, well, this is how much attention we should be giving here. Maybe things have risen here where they haven't in other places, but letting ourselves be directed by the data and then listening to the voices that are in the room.
All right. Thank you, Erik. This is that was a really complicated question, so I appreciate you tackling that. It looks like we have time for one more quick question. I'm going to hand that over to Meg and go for it.
Yeah. So we had one of our audience members shared that they're working on implementing a CME event on PrEP in Peoria in October. And so they were hoping that the panelists today could answer, they're hoping to track new PrEP prescriptions post-event. And they wanted to know, is there any way to track new PrEP prescriptions in a community?
This is Toyin. Not right now, not that I know of, but I do think that that's one of the things amongst a lot of other indices that this new dashboard that our RED committee would be looking at. So one of the things they're going to put on there initially is, what's happening already, who's doing what, who has rapid ART stats, rapid PrEP stats, what hours, just so that everyone has a common place to go to for information, and then to be able to start figuring out what databases can be linked. And so since part of that, the wheels is surveillance and data, and also efficiency of our systems, knowing that, the big prescribed, big places that we use, either with ADAP for round white prescriptions or Walgreens, a Medicaid plan, CVS, at least the large databases might be something that we might be able to start working on to be able to link that, to be able to look at prescriptions and then be able to tab that by. So there is the PrEP VU that actually is a database and a website that anyone can go on to, just like the HIV HIV-U, the PrEP-U, where you can look at PrEP use in the country and you can look at it by state. And so there's some way that there's already data being tracked for PrEP, but hopefully maybe we can then synchronize that and have it downloaded specifically for Illinois and be able to then look at it by zip code and region, because that will be one of the ways we can track progress in what we're making. So as far as I know, I don't know how easy it is to do that without detailing certain providers and clinical practices, but as we're able to start sharing records and harmonizing where the data goes to for viral load data, for engagement data, similar to Ryan White, hopefully it's something that we can also have where we can track that and be able to look by zip code to be able to go down to a community level.
Great. Thank you, Toyin. And yeah, I think that's exactly right. That's something that we have certain aspects of that data, but we really want to try to coordinate it. And that's really one of the goals, especially like you said, under that surveillance goal. So we stay tuned for that. And we're going to try to continue to improve that as we go ahead. So I just wanted to, I was looking at the time, we have reached the hour, and I just wanted to say thank you so much for everyone that tuned in, your great questions. Special, huge, enormous thanks to Toyin and Erik for not only their time today, but their time invested in the past several years to make this a reality. I'm going to say thanks to Meg as well for helping us put this webinar together and all of your work on GTZ. We're really excited for the next 5 years. So I just wanted to draw people's attention once more to our plan online on your screen. You can see where you can go to look up the plan. And then to get in touch with us, as Erik mentioned, this summer we are really starting to build the scaffolding for implementation. We're putting together an implementation council, and the steering committee is also putting together the priorities that will really lay out the work. And to do the work, we will need you all. And so we're going to be forming work groups that will push those ideas forward and make those action steps become reality. And it's really going to take everyone. So please do reach out to us if you have ideas for having your organization become a partner organization, or if you yourself just want to learn more and be hooked into our list, so that when the time comes to form work groups, we will reach out to you. So again, thanks to everyone. We hope this is the first of many conversations, and we will be following up to everyone with links to the slides, or we'll actually just send the slides to you so you can review this as well. And continue on with the work. So thank you again, everyone, today for tuning in, and we will hopefully talk with you all soon.
Thank you. Bye.